Hi, welcome to our channel of IGNOU Audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Bachelor's Degree Programs, Post-Basic Bachelor of Science in Nursing BSc PB, BNS 103 Maternal Nursing, Block 1 Maternal Health and Nursing Intervention, Unit 1 Trends in Maternal Nursing and Family Welfare Services. 1.0 OBJECTIVES. After completing this unit, you should be able to L. Describe the trends in maternal nursing. L. State the demographic trends in India. L. Explain the factors influencing the fertility in India. L. Describe the various methods of contraception. L. Explain the National Family Welfare Program, and L. Discuss the role of nurse in providing quality family welfare services. 1.1 Introduction. Every year approximately 200,000 million women become pregnant in developing countries and more than 500,000 of them die of pregnancy-related causes and millions suffer a significant complication of pregnancy. Additionally, 7 million perinatal deaths occur as a result of maternal health problem, WHO. A woman's health before and after pregnancy is particularly important, not only because she remains healthy but also because her health will largely determine the health of her baby at birth and in the future. Achieving health for women and children determines the health of family and in turn, country at large. The experiences in past have shown us that health of the mothers can be restored by spacing the births. Research has shown that repeated childbirths can lead to nutritional deficiencies, obstetrical and gynecological complications in the mother. This can be reduced by appropriate spacing of births. Hence we learn from our past and implement our strategy in present and change the scenario in future by our continuous efforts. In this unit you are going to identify the trends in maternal nursing and family welfare services to prevent maternal deaths. 1.2 Maternal Nursing, Historical Perspective. In this section of maternal nursing and historical perspective we will acquaint you on concept and scope of maternal nursing. It also deals with the development of maternal nursing in India. Maternal nursing in the Western world. The roots of maternal care in the Western world are also ancient. The first recorded obstetric practices are found in Egyptians' records dating back to 1500 BC. Practices such as vaginal examination and the use of birth aids are referred to in writings from the Greek and Roman Empire, but much of that information was lost in Dark Ages. Socrates regarded midwifery as a noble profession. His own mother was a midwife. Significant discoveries and inventions by physicians in 16th and 17th centuries set the stage for scientific progress. The prominent discovery include obstetric forceps, which were first devised by Peter Chamberlain, 1560 to 1631, and modified by William Smellie, 1697 to 1763. François Morisot, 1637 to 1709, noted that puerperal fever or childbed fever was an epidemic disease. The trends in West suggest that midwives were regarded not as part of the medical establishment but as a separate profession with a unique social role and had formal training and licensing for midwifery. From time to time educated women, daughters of medical men and clergy men became midwives. An obstetrical college for women was founded in London in 1864. Florence Nightingale was pioneer in the efficient training of midwives. In 1862 she organized a small training school in connection with King's College Hospital, but the wards were inconvenient and the scheme was not a success due to outbreaks of puerperal pyrexia. At about this time Semmelweis introduced better caring practices such as hand washing technique with chlorine and lime before attending women at childbirth. A board for the examination of midwives was constituted in London and the first examination was held in 1872 for 6 candidates. The General Medical Council team from 1872 onwards made great efforts to secure state recognition of midwives. The Midwives Institute was established in 1881 with the objective of gaining some sort of recognition from the state. The Bill on Recognition of Midwifery was passed on the 31st of July 1902 in the Parliament in London. Maternal nursing in India. In ancient India, the care of women during childbirth was carried out and taken care by the indigenous village days. Even today in our country about 75% of women are attended by untrained days at the same time of their childbirth, especially in rural areas. The occupation of days are carried in families and they were trained by their mothers or mother-in-laws. By and large this work was done by the lower caste women of the society. There was no formal training given to women to carry out midwifery practices and hence they were unable to handle the complications related to childbirth resulting in increased morbidity and mortality. As early as in 1877 Miss Hewlett of Zanana Missionary Society started the first training school for days in Amritsar. Later on these trainees were also helped by a fund initiated by Lady Curzon to improve the conditions of childbirth in the country in 1900. Madras Presidency succeeded to enact the Registration of Nurses and Midwives Act, 1926, to promote a registered midwife for service during childbirth. The midwifery training was imparted in hospitals by only Anglo-Indian nurses. At that time most of the students were from Indian Christian community. The real change in the field of maternal nursing came after creation of Dufferin Fund. In the initial phase, it was difficult to get Indian girls for training. Dufferin Fund sanctioned grants to various hospitals to build hostel and supply teaching material and employ qualified sisters in nursing schools. This fund was a great help to raise standards of midwifery practices in the country. 1.2.1 Concepts of maternal nursing. In the Western world there was a shift from home confinement to hospital after the Second World War, following the publication of the Peel Report in which 100% hospital confinements were advocated in an attempt to reduce perinatal mortality. Robinson, 1990. By 1970, the midwifery training which was initially started with diploma raised to a degree level and made to reach to master's and PhD level. Consequently the amount of research which is directly related to maternal nursing is growing as a result of these advanced programs of study. Today midwifery, maternal nursing, has developed from being merely a group of handy women who help the mothers to give birth, into a well-educated and respected profession in which there are many opportunities. Midwives have opportunities to render care in variety of ways. For instance, they may be attached to midwifery team, or one-to-one service of an independent practice. Whatever the pattern of care, the aims are the same: to give high-quality services in maternity care. Present concept of maternal nursing in India. Prior to independence, midwifery training had started as a separate course in India. Young girls qualifying at the middle school, class 8, level were selected to undergo this training. In 1946, the Bhore Committee reported lack of skilled services by qualified midwives as one of the causes for high maternal and infant deaths. This committee laid foundation for public health planning and emphasized on the need for qualified midwives and health visitors. A few years later in 1955, Shetty Committee recommended training and posting of ANMs in MCH centers. These ANMs were to be supervised by the lady health visitors. Bishkov in 1959 suggested two types of training in the country. One was auxiliary nurse, midwifery, and another one was general nursing and midwifery. Since independence there was a great deal of change in nursing education. After the inception of Indian Nursing Council in 1947, the general nursing and midwifery was combined as one training of 3 years and 6 to 9 months duration. The second change brought about was to replace diploma in midwifery to ANM course of 2 years duration. Later on, based on the recommendation of Kartar Singh Committee in 1975, multipurpose health workers course was initiated with a duration of 18 months, reducing 6 months from ANM course. The progressive dilution of midwifery training has not been helpful in providing mother and child health services. Therefore, in spite of establishing huge network of sub-centers in India, maternal care did not improve up to the expected level during the last 2 decades. The emphasis on family planning, target achievements and the rigid tubectomy caseload was detrimental to providing timely midwifery services, resulting in a skewed priority of functions. Prakash Sharma, 1989. The maternal nursing practice in the hospital setting has become an appendage to the obstetric But, midwives exerting autonomy to exercise independent practices are still rare. 1.2.2 Scope of maternal nursing. The midwifery nursing practices are influenced by government policies and to some extent by politics or organizations, e.g., NIHFW. They are also affected by various financial constraints. The practices are always necessary as women delivering babies and becoming pregnant are natural processes. They require professional assistance, and increasingly it is the consumers of the services who dictate what those services should be and how they should be delivered. Midwives, maternal nurse, need strength and insight to act as the mother's advocates, whilst recognizing the need for the couple, parents, to decide on their matters concerning their family welfare. This new relationship should, however, facilitate a return to the literal meaning of the word, midwife, of being, with woman. Future of maternal nursing in India. The launching of the Reproductive and Child Health Program and the shift in policies. From demographic targets to comprehensive reproductive health services provides the right atmosphere to make a positive change in the type and quality of services. A report of WHO Study Group, 1994, predicted nurses with highly specialized training would be involved in the high-technology tertiary care. For example, the work of community midwife will involve education about safe delivery as well as development of women's healthcare program that would include planning, nutrition and healthy child birth. Midwifery training practice regulation and standard setting processes are undergoing rapid changes in neighboring countries. Since maternal nursing specialists have to be accountable for their actions and decisions taken by them independently, regulatory bodies like Indian Nursing Council, TNAI, Trained Nurses Association of India, have to enact such regulations to enable maternal nursing practitioners to redirect their practice to meet changing healthcare needs. The maternal nursing expert would be called upon to manage the obstetric and neonatal emergencies. All the more after introduction of Consumer Protection Act in India, the independent practice and autonomy should be observed very carefully. The Government of India, professional organizations and nurses will have to join hands to come up with a long-term plan of action to reduce maternal deaths through skilled maternal nursing services in rural and urban areas. Midwifery has to be separated from being a branch of nursing or an appendage of obstetrics and should receive an independent identity in view of the crucial nature of its role in the health of mothers and children to reduce maternal and infant mortality in our country. Since maternal nursing is a practice-based profession, maternity nurses, midwives need to constantly engage in action research. It is essential to develop a body of scientific and evidence-based knowledge and practices for maternal nursing. Hicks, 1996. 1.3 Family Welfare Services. As you know, India has already crossed 1 billion mark in its population and may soon become the first country in the world to have such huge population. This will greatly strain the resources available in all spheres of daily life. You as a health personnel must make more responsibility to help the country to bring down the population growth. In this unit we will familiarize you about family welfare services and program available in India. You will also learn about various contraceptives. At the end of this subsection we will tell you about National Family Welfare Program and its objectives. The population of the world is increasing in an exponential manner. India is the second most populous country in the world next to China and seventh in land area. India has only 2.4% of world's population with annual growth of 2.1%. About 16 million people are being added every year to the already grown population. High birth rate and declining death rate leads to population explosion resulting in low standard of living, shortage of food supply and malnutrition. India with its high birth rate and low death rate is facing the above problems of population explosion. Family planning as an official program was adopted in 1952 considering the fact that a rapidly growing population would be more of a hindrance than help in raising the standard of living of people. 1.3.1 Demographic trends in India. With the population of 944.5 million in 1996, India is the second most populous country in the world. India's population has been steadily increasing since 1921. The year 1921 is called the Big Divide because the absolute number of people added to the population during each decade has been on the increase since 1921. India's population is currently increasing at the rate of 20 million each year. At the time of independence in 1947, the population of India stood at 344 million. Within 34 years it doubled, and in 2000 India's population had already crossed 1 billion mark. 1.3.2 Factors influencing fertility in India. The word fertility means the actual bearing of children. Fertility depends on various factors, which are as follows. 1. Age at marriage. The age at which female marries and enters reproductive period of life has a great impact on her fertility. In India, the average age at marriage for girls is 18 years, due to which she has a larger reproductive lifespan and hence giving birth to more children. 2. Duration of married life. Studies indicate that 10% to 25% of births occur within 1 to 5 years of married life, 50 to 55% of births within 5 to 15 years, and births after 25 years are rare. So duration of married life has an impact on the childbearing of women. 3. Spacing of children. Studies have shown that if all the births are postponed by 1 year in all the age groups, there is a decline in fertility, which shows that spacing of children will help in reducing the population growth. 4. Education. There is a close association between fertility and education. In states where women are more educated, there is a decline in birth rate, probably because she uses her judgment and takes decision regarding childbearing and rearing. 5. Economic status. Economic status has an inverse relationship with fertility. Higher the economic status, lesser the number of children. 6. Caste and religion. Muslims have a higher fertility rate than Hindus. 7. Nutrition. Virtually all well-fed societies have low fertility and poorly fed societies have high fertility. The effect of nutrition is indirect. 8. Family planning. Family planning is another important factor in fertility reduction. 9. Other factors. Fertility is affected by a number of physical, biological, social and cultural factors such as status of women in society, value of children, gender biasness, widow remarriage, breastfeeding, custom and opportunities for women. 1.3.3 Methods of contraception. Figure 1.1. Chart on methods of contraception. Look at his screen. Spacing methods. A. Hormonal. 1. Combined oral contraceptive, COC, stops ovulation and thickens the cervical mucus, which prevents sperm from entering the uterus. It contains 2 hormones, estrogen and progesterone, in different proportions and brands, comes in 20 to 21 or 28 pill pack, which is to be taken every day. Contraindications of this method are yellow skin or eyes, thrombophlebitis, breast lumps, abnormal genital bleeding, severe headaches, severe chest pains, shortness of breath after exercise, hypertension, diabetes and heavy smoking. 2. Combined injectable contraceptive, CIC, it stops ovulation and thickens the mucus, which prevents sperm from entering in the uterus. It contains estrogen and progesterone hormones and administered by deep intramuscular route at monthly interval. Contraindications are abnormal yellow discoloration of eyes and skin, thrombophlebitis, lump in the breast, abnormal genital bleeding, severe headache, severe chest pain, shortness of breath after exercises, hypertension, diabetes and heavy smokes. 3. Progesterone oral contraceptive, PAC, thickens cervical mucus which prevents entry of sperm in the uterus. It also prevents ovulation to some extent and causes changes in the uterus and fallopian tubes which prevent fertilization. Contraindicated in yellow discoloration of eyes and skin, breast lump, abnormal genital bleeding and severe chest pain. 4. Progesterone injectable contraceptive, PIC, stops ovulation, causes changes in uterus and fallopian tubes and prevents fertilization. Thickens cervical mucus which prevents entry of sperm in the uterus. Contraindications are same like in COC. 5. Subdermal implant, Norplant, the action is same like PIC. It contains progesterone, which is slowly released from capsules implanted under the woman's skin, usually in The upper arm. It is replaced every 5 years. The contraindications are same as COC. B. Intrauterine device. It inactivates the sperm and prevents sperm migration into female genital tract. The IUD also causes changes in the uterus and fallopian tube and prevents fertilization. Contraindicated in presence of sexually transmitted diseases, STD, pelvic inflammatory disease, uterine abnormalities in women who are at high risk of STD. Figure 1.2, intrauterine device. C. Barrier methods. 1. Male condom. Blocks the release of sperm into vagina. The spermicide lubricant in the condom inactivates or kills sperms. 2. Female condom. Blocks the release of sperm in the vagina. 3. Diaphragm and cervical cap. Prevent pregnancy by blocking the entrance of sperm to the uterus. The spermicide that is used simultaneously with it inactivates or kills sperms. It is contraindicated in chronic cervicitis and presence of genital abnormalities which may interfere with insertion. Figure 1.3, Diaphragm and cervical cap. Look at the screen. D. Lactational amenorrhea method, LAM. Prevents pregnancy by stopping ovulation. A. Natural methods. Periodic abstinence. 1. Rhythm, calendar, prevents pregnancy by abstaining from sexual intercourse during woman's fertile period. The figure below shows the safe period. Fig. 1.4. Approximate days of abstinence required by the rhythm method in 28 days cycle. 2. Cervical mucus. Prevents pregnancy by abstaining from sexual intercourse during a woman's fertile periods. The fertile and infertile days are determined by changes in the character of cervical mucus. Fig. 1.5. Approximate days of abstinence required by the cervical mucus method in a 28-day cycle. 3. Basal body temperature, BBT, prevents pregnancy by abstaining from sexual intercourse during a woman's fertile periods. Fig. 1.6. Approximate days of abstinence required by basal body temperature method in 28 days cycle. 4. Symptothermal, prevents pregnancy by abstaining from sexual intercourse during woman's fertile periods. Fig. 1.7. Approximate days of abstinence required by symptothermal method for 28 days cycle. F. Post-coital methods and menstrual regulations. In case of fertilization, this prevents implantation by causing changes in the endometrium. Post-coital and menstrual regulation are not recommended as regular family planning methods. These may be used only as emergency measures in cases of unprotected intercourse, contraceptive failure, suspected genetic abnormalities in the fetus, sexual abuse or rape during fertile days. For post-coital methods, drugs like ethinyl estradiol 0.5 mg or 0.25 mg, levonorgestrel 100 mg and norgestrel or progestogen oral contraceptive 0.25 mg levonorgestrel is taken immediately within 72 hours after unprotected intercourse and repeated 12 hours later. The side effects are headache, nausea, vomiting, breast tenderness and irregular bleeding. Permanent methods or surgical contraception. 1. Vasectomy. It blocks the vas deferentia in the male so that sperms cannot travel to the penis with semen. 2. Bilateral tubal ligation. Blocks the fallopian tubes in the female so that the eggs produced by the ovaries cannot unite with the sperm. We have discussed in brief the various methods of contraception. More and more researches are constantly being undertaken to add new safer, consumer-friendly, cheap and accessible methods. Studies are being conducted to develop different kinds of male contraceptives methods, so that the whole burden of family planning does not fall on the women only. 1.3.4 National Family Welfare Program. India launched a nationwide family planning program in 1952, though records show that birth control clinics have been functioning in the country since 1930. An expert committee of WHO, 1971, defined family planning as a way of thinking and living that is adopted voluntarily upon the basis of knowledge, attitudes and responsible decision by individuals and couples, in order to promote the health and welfare of the family group and thus contribute effectively to the social development of a country. The objectives of family welfare programs are to L. Avoid unwanted births. L. Bring about wanted births. L. Regulate the interval between pregnancies. L. Control the time at which births occur in relation to the ages of parents. L. Determine the number of children in the family. Scope of family welfare services. Now we shall see what are the scope of family welfare program. They are as follows. 1. Proper spacing and limitation of birth. 2. Advice on sterility. 3. Education for parenthood. 4. Sex education. 5. Screening for pathological conditions related to the reproductive system. 6. Genetic counseling. 7. Carrying out pregnancy tests. 8. Premarital consultation and examination. 9. Marriage counseling. 10. Preparation of parents for arrival of the baby. 11. Providing services to unmarried mothers. 12. Teaching home economics and nutrition. 13. Provision for adoption services. Family planning has a direct effect on the health of mother and children. Contraception helps mother to regain health in between the pregnancies, which in turn will help in better health during fetal life and hence a healthy infancy and childhood. Historical background of family planning program in India. India is the first country to recognize the importance of family planning in the world. The developments in the family planning program are 1877, it was Dr. Annie Besant, Secretary of Malthusian League, who raised the issue of population problem and the need to introduce family planning service before the public. 1912 to 1923, Margaret Sanger, a health nurse of USA, headed the birth control program. In 1923, Drive Stopes popularized birth control movement in UK. 1925, Prof. Curway of Bombay started propaganda on birth control. 1930, Mysore Goft started the birth control clinic. 1935, Indian Congress favored the family planning program. 1949, SMT Rama Rao founded Family Planning Association of India in Bombay. 1951, Planning Commission started to formulate the comprehensive programs to check rapid population growth. 1953, India became the first country in the world to start birth control program and started 147 family planning clinics. 1956, a Central Family Planning Board was established. 1962, a Central Family Planning Institute was established during third five-year plan. Local leaders and voluntary organizations were included to propagate the program. 1965, a separate Department of Family Planning was established in Ministry of Health and Family Planning. 1969, during fourth five-year plan, the Government of India gave top priority to the family planning program. 1970, All India Postpartum Program introduced. 1972, Medical Termination of Pregnancy (MTP) Act was passed. 1977, Family Planning Program was renamed as Family Welfare Program. 1978, India was signatory to Alma-Ata Declaration. 1983, Approval of National Health Policy in the Parliament. 1.4 Organization of Family Welfare Program. Now we will acquaint you with the organization of Family Welfare Program at different levels. You are well aware now that family planning is a component of healthcare system. The primary responsibility for delivery of services lies with the government. The delivery of family planning services is through 1. Central government. The Family Welfare Program is 100% centrally sponsored program. Central government controls, plans and manages financial matters. There is separate Department of Family Welfare which was created in 1966. The Secretary to the Government of India in Ministry of Health and Family Welfare is overall in charge of Department of Family Welfare. Special Secretary and Joint Secretary assist him. There is an advisor, mass media and communication, at the rank of Additional Secretary, for technical expertise and advice. There is an Apex Institute, i.e., National Institute of Health and Family Welfare, to promote health and family welfare through education, research, training and evaluation. 2. State level. In the states there is State Family Welfare Bureau, which is part of the State Health and Family Welfare Directorate. 3. District authorities. There are District Family Welfare Bureau consisting of 3 divisions headed by district Family Welfare Officer, Mass Education and Media Division in charge and District Mass Education and Media Officer.
4. Primary Health Center. There are 3 medical officers at PHC level to provide essential healthcare and family planning services. The work of sub-center is supervised by Health Assistant, M, and Health Assistant, F. The activities in the sub-center are managed by the Health Worker, F, and Health Worker, M. Family planning services to the women is the responsibility of Health Worker, F, whereas the services to male population is of Health Worker, M. 5. Village level. There is one village health guide for every 1,000 population. They are responsible for educating and informing the people about family planning and also to supply Nirodhan oral pills. Trained days also work for 1,000 population, who act as a counselor for family planning and motivate mothers to adopt family planning methods. 6. Role of non-government agencies. The role of NGO in private practitioner is well organized and government has created a nationwide social market for Nirod through them. 1.5 Role of nurse in family welfare services. Now we will discuss the role of a nurse in providing the family planning services. The nurse is expected to give a special attention to the unique need of couple, parents. You need to counsel them for meeting their need. Now let us see what is counseling. Counseling is a way to help individuals and families understand and cope with their situation, so they can make decisions and take action for better health. As a nurse you have following role to play. 1. Counselor's role. As a nurse you will come across with difficult couples requiring special care and advisors. You need to clear their doubts and assist them in making decisions for themselves. 2. Administrative roles. As a nurse you may be called upon to participate in organization of family welfare department at national, regional and local level. She may have to set up a family welfare clinic and manage the administrative activities. 3. Supervisory role. Nursing personnel are responsible for practical supervision and in-service education of their health workers and professionals. 4. Functional role. As a community health nurse she will be responsible in finding eligible couples. Help the couples to choose a suitable method of contraception. She may be asked to run a clinic or assist the doctor for various other activities related to family planning. 5. Educational role. The main role of a nurse is to educate people about family planning. The health education can be held in the health centers, hospitals, clinics, schools, homes etc. 6. Role in research. The nurse should have an enthusiastic mind to answer the questions and find the solution to it. As a member of the health team she needs to have enough data to answer such questions. She keeps accurate records to analyze the facts to help in further planning of the family planning activities in her area of assignment. Check your progress. 4. List the role of the nurse in providing quality family welfare services. 1.6 Summary. Nursing has been in existence from the time immemorial. In the initial phase it was in a very crude form. There was no scientific base for it. But slowly nursing had been transformed and now it is having a strong scientific basis as well as its own body of knowledge. In future the maternal nurse may be asked to act as an advocate of mothers, an expert to manage obstetric and neonatal emergencies. Her role may be more well defined and demand professional expertise to reduce maternal and neonatal mortality and morbidity. In view of the future demand of maternal and child health services, the nurse has a vital role in family welfare services. She needs to be more acquainted with new methods of contraception to help women to adopt as per her choice. She needs to be an educator for masses, a good administrator to make the program a success and an efficient supervisor. So the nurse has a great responsibility to play in delivering the family welfare services to the people and make it a people's program. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.